Endocrinology is an entire subsection of internal medicine. If you're studying for step 2, you have to watch the endocrine videos. But if you're studying for your surgery shelf, this is going to be broad strokes, high-level view of the diseases that are both endocrine and can be treated surgically. You're not going to get a lot of the little details. There's not a lot of understanding. It's just how you recognize what the diagnosis is on the vignette and what you do about it. The idea being here, the answer is going to be surgery, so you have to arrive at the right diagnosis. This is much more step prep than it is life prep. First, we're going to start off with is thyroid nodules. This is probably the most important because it's the most common of the diseases that we're going to talk about in this lecture. And if you've got a thyroid nodule, what you want to do is decide, does this person have cancer? If the answer is yes, you need to cut it out. If the answer is no, you can just watch and wait. And now, while it's going to come down to their risk, their previous exposure, what the nodule looks like, and a lot of other details, I want to give you a simple way of approaching thyroid nodules. The first thing you do is say, is it active? That is, if it's active, it should be shutting off on a feedback mechanism, TSH. So if TSH is low, then you have a low-risk nodule. And it doesn't matter how you found this nodule, whether it was on palpation, on a CT scan, ultrasound, or something else. If you have a low TSH, it's a low-risk nodule because it's probably hyperfunctioning. To make sure it's the nodule that's hyperfunctioning, you're going to get a radioactive iodine uptake, a RAIU scan. If the RAIU scan shows a hot nodule, that is, the hyperthyroidism is caused by that nodule, you have a hyperfunctioning nodule, and you treat this with medicine. You treat the hyperthyroidism, methimazole or PTU, and then you can get rid of it. And you're going to use resection, iodine ablation, whichever mechanism you choose based on the underlying diagnosis. That's internal medicine. But if the RAIU scan does not show a hot nodule, even though the thyroid is hyperfunctioning, it's not the thing you found, not the nodule that's causing it. So all of a sudden you have a non-functioning nodule. This is risk for cancer, so you're going to do the FNA. Now likely you will get the ultrasound first, but if you're already at the point of TSH RAIU scan, there's no way you're going to avoid getting the biopsy, the fine needle aspiration, but it might be done under ultrasound guidance. All right, if you come back up here, if the TSH originally was either elevated or normal, then you know there's no hyperfunctioning nodule, and that's a high-risk nodule. High-risk nodules are going to go to an ultrasound, and again, you're going to make this determination based on a lot more than just the size. Radiation exposure, previous history of cancer, how old the patient is. But basically what you're looking at is the size. What I want you to remember for this course is if that nodule on ultrasound is greater than 1 centimeter, that's considered large, high risk for cancer, going the FNA. If, on the other hand, it's less than 1 centimeter, it's small, and you can observe. You watch and wait, getting an ultrasound every 6 months, and if it transitions into a large nodule, that is, it's growing, you end up at the FNA. But then if you've gotten the FNA, how do you interpret that? This is the biopsy. You've got 3 options. If it is obviously cancer, that's no good, you cut it out. If it's obviously not cancer, that's good too, but you're going to watch and wait, observe every 6 months with an ultrasound. And as that nodule stabilizes, you can start pushing that out further and further, but initially you want to make sure that it's not growing, you just missed it with the needle. And that draws us to number 3. If you're not sure, you immediately repeat the biopsy. Because if you're not sure, you don't want to wait a full 6 months, repeat the biopsy right away. Most to know about thyroid disease, but also the most relevant. Another organ that can cause some problems is the pancreas. A gastrinoma, Zollinger-Ellison syndrome, produces, you guessed it, gastrin. And what gastrin does is stimulates parietal cells to make acid. So the person's going to produce a lot of acid, more than they need, and it's going to burn stuff. So a patient with a gastrinoma will present with virulent ulcers. Peptic ulcer disease that doesn't get better with proton pump inhibitors, or when you do the endoscopy, there's ulcers everywhere. Gastrin is also a stimulant, so it happens to cause diarrhea. The way you're going to arrive at gastrinoma is this peptic ulcer disease that won't go away. The diagnosis begins with a gastrin level, and you are supposed to be off PPIs when you take a gastrin level because they may artificially elevate. If you have a small elevation in gastrin, triple digits, what you need to do next is a secretin stim test. Secretin should turn off parietal cells. In the setting of gastrinoma, it doesn't, so gastrin levels will elevate with stimulation of secretin as opposed to turn off. If the gastrin level goes up with secretin, that is a sign of gastrinoma. But if the gastrin levels were already really high, we're talking 4 digits in the thousands, then you have your diagnosis. It can't be anything else. You just have to find it. So you do that with a somatostatin receptor scintigraphy or a CT scan, some way of localizing the disease. And of course, if the secretin stim test is positive, that takes you also to localize. Once you find it, you cut it out. And you're not cutting it out because it is itself malignant, but because it can cause malignant transformation into gastric cancer. Also, the virulent peptic ulcer disease, which is causing the patient a lot of discomfort. Stimulation of the parietal cells leads to gastric cancer, so you want to get rid of that gastrin. The pancreas also deals with insulin, and an insulinoma autonomously secretes insulin. Insulin decreases your blood sugar, so not surprisingly present with hypoglycemia. But it's hypoglycemia even in the presence of fasting. And hypoglycemia is defined both by the low number and the symptoms of hypoglycemia: diaphoresis, presyncope, tachycardia. In fact, if you find someone who has true hypoglycemia and is not a diabetic, you admit them and you make them fast and you wait for them to have an event. And when their blood sugar goes low, you draw labs and of course immediately give them sugar IV. What you're getting at is an insulin level, C-peptide, and a sulfonylurea screen. Because they're having a hypoglycemic event, we think it's from insulin. The insulin level will be elevated. If that insulin is coming from their own pancreas, the C-peptide will also be elevated. If they are injecting insulin, there won't be any C-peptide elevation. But you can still make it look like you've got a tumor by taking a sulfonylurea, taking excess, which induces insulin to be secreted from your pancreas. So an insulinoma will have elevated insulin, elevated C-peptide, and a negative sulfonylurea screen. If you suspect an insulinoma, you get the CT scan to identify it, and the treatment is resection. Don't forget to fix their glucose when they're immediately hypoglycemic. Also in the pancreas in regards to sugar is a glucagonoma. And this is definitely the rarest and the lowest yield. You might think, well, glucagon is the other hormone, the counter-regulatory hormone to insulin, so diabetes must be the way it presents. While they might have a little touch of diabetes, what you're looking for is a very specific phrase. The patient is going to present with migratory, necrolytic dermatitis. It is unfair for them to give you a picture of that to know what it is, and it's really hard to use English to describe what that is. So if you see the words migratory necrolytic dermatitis, glucagonoma, job is done. Diagnosis is made by getting a glucagon level and having it be very elevated, and a CT scan to identify it. If you identify it, cut it out. Now you might be tempted to do a glucose suppression test. If you give a bunch of glucose, the glucagon should go down. In a glucagonoma, it won't. You don't need to do that. If the glucagon level is elevated and you've got migratory necrolytic dermatitis, get the CT scan and resect it. Leaving the pancreas, we finish with hyperparathyroidism. And we're going to discuss primary hyperparathyroidism because secondary hyperparathyroidism is a product of chronic kidney disease and tertiary is a product of secondary. As the surgeon, you're going to be resecting hyperparathyroid glands for primary hyperparathyroidism. The patient is going to present with an elevated calcium, a low phos, and an increased parathyroid hormone. Parathyroid hormone is supposed to be turned off by a high calcium. In hyperparathyroidism, that's primary, there is one parathyroid gland that is just making parathyroid hormone and not listening to the calcium. Parathyroid hormone causes reabsorption of bone, increasing calcium, absorption of calcium in the gut, increasing calcium, and resorption of calcium from the kidneys. So, under the influence of parathyroid hormone, calcium will go up. Parathyroid hormone resorbs bone, increases phosphorus, increases absorption in the gut, increases phosphorus, but at the level of the kidney, induces excretion of phosphorus. Kidney always wins, and because we're talking about primary and there is no CKD, low phos. Now the parathyroid hormone is supposed to be turned off by high calcium, but it's not. So the biochemical diagnosis is made high calcium, low phos, high parathyroid hormone. But because it's resorbing all this bone, you might present with bone pain. And you might even see those lesions on the bone, osteofibrosis cystica, the brown tumor. That's when this goes out of control. The diagnosis is made by getting the biochemical diagnosis, calcium, phos, and parathyroid hormone. But you want to know which one is the hyperfunctioning gland. Remember, you have 4. The sestamibi scan tells you which one it is, and then you go cut it out. But you have to be careful because the other hyperparathyroid glands have atrophied. They've correctly turned themselves off under the influence of a high calcium. So when you remove the bad one, the other ones may take time turning on. What you might get is post-op hypocalcemia, which will present as perioral tingling, Trousseau's sign. You increase the blood pressure cup, their hand does this. Release the blood pressure, their hand goes back to normal. Rajvostek sign, it's a failure of the facial nerve reflex to dull over time. If you see hypocalcemia, you give them IV calcium, and eventually their other hyperparathyroid glands will turn on. All right, so this was just a hodgepodge of different diseases that you have to know about. They are discussed in more detail in Endocrine in Medicine, but as you're preparing for your surgery shelf, this is a high-order view giving you the essential details to make the right answer on the test. That's surgical endocrinology. Become a better doctor. Subscribe now to get access to our premium content.